Hello, I'm Dr. Russell Barkley. I'm a clinical professor of psychiatry at the Medical University of South Carolina. Welcome to this internet course on parent counseling and home management of ADHD children and teenagers. Before we begin, let me show you my sources of support for the previous 12 months so that you can evaluate whether there is any potential conflict of interest with the contents of this program. Although I do receive a retirement pension from the University of Massachusetts Medical School, I'm certainly not retired. I've spoken for a number of associations and healthcare organizations during the past year. You can see a list of these here, for which I've been paid for these presentations. I also have a number of products in the ADHD marketplace, such as books, videos, newsletters, and courses such as this one. And I do consult with and speak for many of the major pharmaceutical companies that have ADHD products in the current marketplace. Let's begin our course. I'm going to focus on the essential characteristics of counseling parents of ADHD children, and also some of the essential steps in training parents in the home management of ADHD. Any treatment package, I believe, has to include the following 5 major ingredients. The first of these is that a thorough and proper evaluation has been conducted in order to establish the diagnosis of ADHD, as well as any other comorbid conditions that are likely to be present. As you may have learned from taking my course on comorbidity on this website, more than 80% of children and adults with ADHD have at least one other disorder, and more than half of them experience at least 2 other disorders besides their ADHD. And so it's important that the evaluation establish the nature of the child's presenting complaints and the various disorders that may be present and explain those complaints. The second component in any treatment package for ADHD children is the need to educate parents, or in the case of adults with ADHD, the adults themselves, about the exact nature of ADHD. I'll have more to say on this later in this course, but suffice to say here that making sure that patients and families have a thorough understanding of the nature, life course, risks, and management approaches for ADHD is essential. Indeed, some studies show that this step in intervention creates the greatest change in families and improvement in ADHD child behavior of any of the subsequent steps I'm about to cover. The third part of the treatment package may be the need for medication. Research suggests that between 70 and 80% of children with ADHD are likely to require medication at some point during their child or adolescent years to supplement the other interventions that are being done for the child. Medication is the most effective treatment component in terms of empirical research support. More individuals are changed by medication, that is to say improved, and the degree of improvement is greater than that achieved by behavior management, parent training, school intervention, or other psychosocial interventions for ADHD. And so for many children and teens, medication will be an essential part of the total treatment package that is prepared for them. The fourth component of any treatment package is the need to work with families and teachers on methods of modifying the child's behavior so as to reduce inappropriate or disruptive behavior and to increase prosocial behavior and behavior that contributes to effective academic performance and social acceptance. Finally, for many children, there is the need to alter the environment itself, that is, the structure of the physical environment, in order to make accommodations for the disabilities that ADHD creates. These accommodations may be changes in the structure of the home life, they may be changes in the nature of the school classroom or the curriculum, or they may involve changes in the kinds of community activities in which the child may be involved. The difference here between modification and accommodation is that in approaches to modification, efforts are made to change the behavior of the child by changing the consequences that others provide to that child, whereas accommodations refer to changing the physical environment around the child so as to make certain behaviors more or less likely to occur in order to help the ADHD child be more effective at meeting the demands of their life. With these components in mind, let's go through some of the specific features of any parent counseling program. One of the things that I like to do at the beginning in counseling parents following the feedback conference of the evaluation is to review with them the various empirically supported treatments for ADHD. Empirically supported means that these have scientific studies behind them that support their effectiveness compared to no treatments or placebo treatments in helping families to cope with the ADHD child and in improving the child's behavior. The first of these empirically proven treatments, as I've already mentioned, is the education of parents themselves about the nature of ADHD, its causes, its life course and risks, and the proven interventions that are available for ADHD. Again, I'll have more to say on this shortly. Obviously, another empirically proven treatment is the use of psychopharmacology with ADHD, particularly the FDA-approved stimulants, the non-stimulant atomoxetine, and the non-stimulant guanfacine XR. These will be described in a separate course on this website on medication management of ADHD. I invite you to take that course. A third science-based intervention for ADHD children is the training of parents in behavior modification and other child management methods to help them cope better with their child's behavior, reduce the extent of parent-child conflict, and improve their child's success and effectiveness at meeting daily demands. Notice on this slide that parent training or other family-based interventions are age-limited in terms of their effectiveness. That is to say that they are much more effective when done with younger children, those 11 years of age and younger, than they are with children who are older. This is not to say that these interventions do not work with adolescents with ADHD, but as you see here, the extent of improvement one is likely to achieve and the percentage of individuals likely to respond to the program are considerably greater in childhood than they are in adolescence. As you see here, nearly 75% of children show clinically impressive or clinically significant improvement in their behavior following a parent training program. This falls to about a third of that rate by the time the child reaches adolescence, where only about 25 to 30% or slightly more of ADHD teenagers are likely to respond to programs in which the parents are being used to intervene with the adolescent. Now, this age-related decline in parent training effectiveness makes sense when we consider that the sources of influence over an individual's behavior is changing with development. As children mature, the influence of parents is declining rapidly with age, such that by middle to late adolescence, only about 6 to 10% of the variation in adolescent behavior problems has anything to do with parenting or with things taking place within the home that are shared with their siblings. Increasing over time is the effect of outside influences known as non-shared environment or unique events. These may be things like exposure to particular teachers at school, exposure to other adults in the community, such as coaches, people who provide services through church or scouts, and so forth. But of course, one of the most powerful influences that is increasing with age over an adolescent's behavior is that of peer influences. Finally, evidence suggests that genes increase their influence on variation in human behavior with age. For instance, take intelligence, for example. The extent to which inheritance or genetics contributes to variation in child intelligence is about 55% in childhood. However, by age 30, genes account for between 70 and 80% of the variation in human intelligence. This suggests several possibilities: that genes are increasing their effects with time. Another possibility is that people are selecting into particular environments as they become older, and one of the bases they are using to choose particular environments, or to niche pick as it's called, is their native abilities, capacities, and talents, so that people self-select into environments in which they are more likely to be successful. And part of the reason they are choosing those environments has to do with differences, that is, genetic differences, in those abilities. This would result in differences in human behavior or in human traits appearing to be more genetically influenced with age, when in fact what we are seeing is people self-selecting into environments in which they are more competent, and part of those competencies are genetically based differences. Whatever reason, we see that genetics increases in its explanation of individual differences with age, and this may also account for why, by adolescence, parental influence is diminishing, while environmental influences outside the home are increasing, and genetic differences are increasingly having an effect on the outcomes of adolescence. By 12 to 14 years of age, I encourage clinicians to employ a different approach to intervention, and that is to work with both the families and the teens on problem solving and communication training. I'll have more to say about this later, but this approach is designed to work directly with teenagers and parents rather than just working with parents, as is the case with parent training programs. Even here, however, notice that the success rate of our programs for teenagers is only about 30% when using a family therapy-based program. And again, this is for the reasons that I've given above. My own research shows that it is best to combine such family training in problem solving with parent training in child behavior management methods to achieve the greatest impact on the greatest number of individuals. Now, besides these interventions for families, it is certainly helpful to educate teachers about the nature of ADHD, its causes, and its treatments, so that they are not providing inappropriate or outdated information to families whose children with ADHD are in their classroom. Also, there is abundant evidence that training teachers in classroom behavior modification techniques can be very useful in improving the behavior and the academic performance of ADHD children in school settings. For more on teacher education and classroom behavior modification, I invite you to take my course on school management of ADHD on this website. ADHD children are also eligible for special educational services under two federal laws, the Individuals with Disabilities in Education Act, or IDEA, and Section 504 of the Disability Rights Act. Therefore, clinicians should encourage schools to conduct evaluations under both federal laws to determine if the child might be eligible for services under either or both of these forms of special education. Research shows that regular physical education can be beneficial for ADHD children. The reason for this is not clear. It may simply have to do with the fact that routine aerobic exercise allows the child to expend their energy and hyperactivity and might therefore result in a decline in their symptoms temporarily. On the other hand, it's possible that routine exercise increases dopamine availability in the brain, providing for a short-term coping mechanism for ADHD children in that it results in a temporary decline in their symptoms. Whatever the reason, routine exercise is beneficial for ADHD, perhaps more beneficial than it is for other psychiatric disorders of childhood, and therefore parents should be encouraged to include ADHD children in routine physical exercise programs. Also, there is evidence to suggest that ADHD children are prone to obesity, and therefore routine exercise might help to head off this particular life course risk as well. Now, I have listed neurofeedback, or EEG biofeedback, on this slide as empirically proven. However, recent evidence may call that into some doubt. Let me explain. EEG biofeedback involves the modification through reinforcement of children's efforts to increase particular bandwidths of the EEG and to reduce other bandwidths of the EEG that are known to be associated with ADHD symptoms. It is hoped that by using reinforcement methods to condition these particular aspects of the EEG pattern, it will result in a reduction in ADHD symptoms. Now, neurofeedback has been around for nearly 2 decades, and certainly its proponents have claimed that it is a very effective treatment for ADHD children. But when one examines the actual scientific basis for these claims, the results of these studies are rather mixed. Early studies that were done by biofeedback proponents were often poorly conducted, did not have sound scientific designs, and often reported substantial improvements in ADHD symptoms. But these treatment studies often did not include placebos or sham interventions to control for the amount of attention that children were receiving in the biofeedback condition. Also, in many of these studies, parents, clinicians, and teachers were not blind to the intervention that the child was receiving. Such blindness is essential in order to control for expectancy effects or placebo effects in such studies. Some studies were done that did involve these kinds of scientific controls, and they didn't find much effects of the intervention. However, last year a large study was conducted in Germany that was relatively well conducted and had a number of such scientific controls, and it did find improvement in ADHD symptoms at home and at school. Now, this intervention did not necessarily involve clinician or parent blindness to the treatment conditions. Nevertheless, the study was relatively rigorous, and it did find improvements in ADHD symptoms. In contrast, last November of 2010, a study was reported from Ohio State University at a scientific meeting. This study was the most rigorously done of all neurofeedback studies to date. It included a sham or placebo intervention, and it kept parents, teachers, and clinicians blinded to the specific neurofeedback condition that the child was receiving. That is to say, whether the child was receiving the placebo or sham treatment or the actual neurofeedback treatment. This study reported no benefits of neurofeedback relative to the sham intervention. So at this point it remains unclear whether neurofeedback does provide improvement in ADHD symptoms or not. So I advise clinicians to view neurofeedback as a promising experimental treatment for ADHD, one which in the future may well have an established scientific basis for it. But at the time, studies on this issue are relatively mixed. My own feeling is that neurofeedback should not be offered to families as the first-line intervention. Families should be provided with the other interventions you see on the previous slide and on this slide first, and that is because there is substantial scientific evidence for the effectiveness of these treatments. Once these treatments have been provided, if the family is of relatively high economic status or has the financial means to pay for neurofeedback treatment, then if they wish to pursue it, feel free to do so. But because this is a very expensive treatment, often costing between $4,000 and $6,000, and because the science on which it is based remains relatively contradictory in the scientific findings, I do not encourage this as a first-line intervention. Moreover, it remains to be seen exactly what is the basis for the improvement in symptoms in ADHD children, since some studies have reported an improvement in symptoms even though there has been no improvement in the EEG, or the results for the EEG biofeedback were simply not monitored at all. Some children with ADHD may require residential psychiatric treatment, but typically this is not done for their ADHD. ADHD can be managed quite nicely on an outpatient basis. Often residential treatment is needed for the management of one of the comorbid disorders an ADHD child may experience, such as bipolar disorder, severe conduct disorder, or, in some cases, a more severe form of one of the autistic spectrum disorders. You will see here that my own follow-up study found that only 5 to 8% of ADHD children received residential treatment across their life course. Obviously, parents may be in need of interventions for their own disorders as well. It has been my experience that nearly a fourth or more of parents of ADHD children need to be treated for the same disorder as well, and that is because of the high rate of genetic contribution to ADHD. For more on the causes of ADHD, please see my course on this website on the etiologies of the disorder. But suffice to say that parents of ADHD children often have a higher rate of psychological disorders, and specifically adult ADHD. These disorders can interfere with the provision of treatment services for the child's disorder. For instance, research shows that parental ADHD is one of the best predictors of failure by parents in behavioral parent training programs, and therefore it should be standard practice that parents are screened for ADHD and other disorders before enrolling them in any behavioral parent training programs. I believe that parents should be screened whenever they bring a child to a clinic with the question of ADHD in the child, in order to determine if the parent may have the same disorder or related disorders. I often encourage parents of ADHD children to locate nearby parent support associations for ADHD and to attend these monthly meetings. For instance, the National CHAD organization, which stands for Children and Adults with ADD, often has support groups in most of the states in the United States. You can go to their website, chad.org, in order to determine if there is a support group in your community. Even if there is no CHAD organization, sometimes there are independent parent support groups that have been organized by local parents, and even these can be beneficial for parents to attend. Also, the Attention Deficit Disorders Association may have support groups in the area as well. This organization is not as large as CHAD, but still may have some support groups within your region. Now here I list some of the interventions that may be promising but do not have sufficient scientific support yet for me to recommend them as a science-based intervention. As I've already indicated, it may be that neurofeedback treatment belongs on this list rather than on the proven treatment list. Besides neurofeedback, there has been an effort lately to see if ADHD symptoms could be improved by training children in executive functioning, and specifically practicing working memory. Now, if you've taken my course on this website on the role of executive functioning in ADHD, then you know that ADHD interferes with a variety of the brain's executive abilities, and one of those with which it specifically intervenes or interferes is with working memory. Working memory is the ability to hold information in mind that is being used to guide behavior toward a goal or a task. Often it is tested through nonverbal and verbal working memory tasks. These involve such things as practicing digit span, particularly digit span backward, or practicing spatial memory tasks where the individual has to hold information in mind about a stimulus array in order to be able to accurately point out where that information was located after the array has been removed. However it is tested, such tasks indicate that ADHD children have major problems with working memory, both verbal and especially in nonverbal working memory, in addition to their deficits in inhibition and in planning and problem-solving abilities. Over a decade ago, scientists in Sweden, such as Torgel Klingberg, have developed a program for working memory training, known as CogMed. CogMed involves practicing working memory tasks for at least 45 minutes to an hour a day. These tasks are completed using a handheld video game system, and the child practices under the supervision of their parents, and often the parents are encouraged to provide reinforcement to the child for engaging in the practice sessions, which can become relatively boring after the first few sessions. Parents also are requested to check in weekly or more often with clinicians that are supervising this intervention in order to ensure that parents are following the program appropriately, and to provide some coaching and structure to the parents and child as well. The initial reports on CogMed were quite positive. They showed that practicing working memory not only expanded working memory capacity, but did result in a reduction in ADHD symptoms in the home and in the school environment. However, these initial studies were done by the developer of the program, and therefore it would be most important for them to be replicated by someone who does not have a financial interest in the outcome of the treatment study. Subsequent studies have attempted to replicate these findings. Indeed, I'm aware of at least 5 other studies that are ongoing in the United States now that are trying to replicate the initial promising approach. Recently, one study was published from Europe that did show, or that did replicate, the initial findings by Klingberg, showing that working memory training over a period of 6 months or longer did result in improvements in ADHD symptoms. However, another study recently reported earlier this year in the United States using the CogMed program did not find improvements in school ADHD and found only modest improvements in parents' reports of ADHD symptoms in the home environment. So at this time it's not clear whether CogMed will prove to be an effective intervention for helping individuals cope with their ADHD symptoms. It may be that this intervention is useful. Even if it is, however, studies indicate that the results of working memory training are not permanent, that once training is discontinued, that the impact of the training may begin to decline with time, such that retraining may be needed after 3 to 6 months. On the other hand, it may be that CogMed, even if it is an effective training program, could be provided through other more cost-effective means. For instance, the Nintendo DS system comes with free software when it's purchased called BrainAge. BrainAge involves exercises very similar to those in the CogMed program that involve practicing working memory, but it also provides games for practicing inhibition and other executive functions. This approach to executive function training, that is, using a handheld video game system like Nintendo, is considerably less expensive than the CogMed program. Also, there are a number of websites on the internet that allow one to register and pay a monthly fee to have access to games that are believed to improve various mental functions, such as working memory and executive functioning. These websites are considerably less expensive than the CogMed intervention. When I last checked, CogMed was being provided in my community for between $1,200 and $2,000. These other internet programs or the Nintendo system would be about the cost of 1/10 of that. Nevertheless, training in executive functioning, such as working memory, remains an experimental intervention for ADHD that has not yet been proven in enough scientific studies in order for us to accept this as a proven intervention. There is a large-scale federal-funded program going on in New York City by Howard Abacoff and his colleagues at NYU Medical School that involves training children in time management and organization strategies. This is a school year-long intervention that involves working with the children, working with parents, and training teachers in order to help children in their time management and organization. The results of this study are not yet available. It'll be interesting to see whether these executive abilities can be trained and whether the intervention effects can be sustained after the intervention has been withdrawn. Now, there are a number of books and manuals in the marketplace at the moment that advise teachers and parents on how to improve executive functioning at home and at school. None of these have been subjected to scientific studies. Therefore, it is not clear whether parents and teachers, using various executive strategies with their children, can improve their child's executive functioning and therefore improve their child's ADHD symptoms. Some work was done in the 1980s and 1990s using computers to train children to improve their attention span and the focus of their attention. Such training was often done using reading and math programs in order to help reinforce the children for continuing to sustain their attention to these computer training programs. The results of these studies were mixed. Several studies in Canada reported modest benefits, while other studies in the U.S. and in Canada found no benefits at all of these training programs when they were compared to sham training interventions. So at this point, it is not clear whether attention deficits can be improved through direct training using computer systems and software. Another experimental intervention program that is having some promise is the Challenging Horizons program. This is an after-school program provided at a teenager's high school. Usually is provided by trained paraprofessionals. The intervention involves a variety of methods that were proven to be useful for ADHD individuals in summer treatment programs such as that provided by Bill Pelham and that provided in the multimodal treatment study of ADHD funded by the federal government. This summer program involved classroom management and behavior modification, supplementation of academic skills through tutoring, training individuals in athletic abilities and sports participation, working on social skills, and just general behavior modification techniques. The Challenging Horizons program attempts to take all of these methods and provide them to teenagers in an after-school program that meets at the teenager's high school. The beauty of this intervention is that the teen does not have to go to a psychology or psychiatry clinic to receive intervention. Therefore, it reduces the stigma associated with this treatment program. Also, I believe it increases the likelihood that a teen will participate in the program because it removes a series of obstacles to receiving the intervention. Those obstacles, for instance, are having to commute to the clinic and to receive the intervention by a trained professional. In any case, several studies have been published in the past few years, one of which you see cited on this slide, that have shown that the Challenging Horizons program does provide some benefit to ADHD teenagers in the school environment. Another promising program that still needs more research is teaching parents to be friendship coaches to their children. Now, as I will mention on the next slide, evidence shows that social skills training provided directly to ADHD children by clinicians has not been especially effective in helping to improve the social behavior of these children. On the other hand, the friendship coaching model approaches this by training parents to be the coaches or the therapists and having parents work daily with their children using the typical social opportunities the children may have to relate to siblings and other children as a basis for training the children in more appropriate social skills, and just as importantly, reinforcing the children for using those social skills in these natural settings and opportunities for relating to other children. One paper by Makami found that using parents as friendship coaches did result in improved social skills and social relationships in ADHD children. So if this is replicated, this approach might be a better approach to social skills training than doing direct training of social skills in the clinic by a clinician. Excuse me. Another approach to working with individuals that is promising but experimental is cognitive behavioral therapy for adults with ADHD. Now, this isn't a child or adolescent intervention. That is because research has already been done showing that cognitive behavioral training of children was not beneficial in improving their ADHD symptoms or behavior. So, in other words, teaching impulsive children to talk to themselves and to engage in self-monitoring and self-reinforcement did not turn out to be especially effective for children. However, recent studies with adults with ADHD suggest that cognitive behavioral training can be an effective supplement to medication for helping ADHD adults to cope better with their ADHD symptoms and to improve their executive functioning. You see a number of programs that have found such benefits on this slide, such as those conducted by Steve Safran and colleagues at Harvard University and Mass General Hospital, programs conducted by Russ Ramsey and Anthony Rostaine at the University of Pennsylvania Department of Psychiatry, and most recently, Mary Salanto at Mount Sinai Medical School in New York City. All of these authors now have training manuals commercially available for clinicians if they wish to learn how to do this intervention with adults. But as I've said, the evidence shows that such training, while useful for adults, is not particularly useful for children. Now I'd like to discuss with you the unproven or disproven therapies for ADHD, and I encourage you to discuss these with families so that they can be aware of this information as well. For a number of years it was popular to restrict children's diets in order to try to improve their ADHD. This was because it was believed that there were things in the diet that were provoking allergic reactions or otherwise exacerbating ADHD symptoms in children. For instance, during the 1980s and even through the 1990s, it was popular among parents to believe that sugar provoked ADHD symptoms, and therefore removing sugar from the diet might be effective at helping to reduce the child's ADHD. This turned out not to be the case. Sugar has no effect on children's behavior, according to double-blind, placebo-controlled trials. Indeed, it turned out that it was parental expectations about sugar that turned out to be the basis for the reports of improved symptoms, not the actual removal of the sugar from the diet itself. It was also popular in the 1980s to believe that additives, colorings, preservatives, and other chemicals added to foods might be a source of allergic reactions that produced an increase in ADHD behavior. Indeed, Ben Feingold and others believed that more than 70% of ADHD cases in the U.S. were the result of food additives in the diet. Subsequent studies, including very well-controlled studies using placebos at the University of Wisconsin, were conducted in the 1980s, and they found absolutely no basis to Feingold's claims. Indeed, there were no differences between children who were on the elimination diets and children who were on placebo diets, so long as parents were not aware which diets contained the additives and which did not. Therefore, elimination diets were dismissed from consideration. Nevertheless, a series of subsequent studies did find that a very small percentage of children might well have allergic reactions to food dyes, colorings, flavorings, and preservatives. This body of research suggested that about 5% of ADHD children might well react adversely to these additives and therefore exacerbate their ADHD symptoms. These were primarily children in the preschool years. But what these studies did show is that 95% of these children did not have such allergic reactions. Therefore, eliminating these substances from the diet would not be a particularly effective widespread intervention for ADHD, but it might be useful for a few ADHD children where it could be shown that they were in fact having allergic reactions to these additives. Now, within the past few months, a study conducted in the Netherlands called the INCA study was a widespread study that did attempt to examine whether or not removing substances from children's diets might be beneficial for ADHD. This study reported that such elimination diets were effective at reducing the children's ADHD symptoms. Now, one problem with the intervention is that clinicians and parents were not necessarily blinded to which intervention the children were receiving. and therefore it would be useful for this study to be replicated again using more rigorous and blinded scientific procedures. Nevertheless, I have seen a number of reports in the popular media lately claiming that diets may well be an effective approach for ADHD. We have to be very cautious about these claims. As I've already indicated, there is an abundant body of evidence prior to the study in the Netherlands that showed little, if any, effects of these elimination diets. And there is reason to be suspicious about the methods used in the Netherlands study as to how it may have produced the results that it obtained, such as were parents and clinicians expecting the intervention to improve symptoms, and therefore what we are seeing here is purely an expectancy effect on the symptom ratings provided by these individuals. Time will tell, but at this point I remain very skeptical about the value of these elimination diets in helping individuals cope with their ADHD symptoms. Another intervention for which there is no evidence or proof of success is adding substances into the diet, such as using vitamins or large doses of vitamins known as megavitamins, or adding in antioxidants such as fish oils or pycnogenol, or adding in minerals or trace elements into the child's diet. Although this is a very popular alternative remedy for ADHD, and research suggests that as many as 60% of parents of ADHD children may try these dietary supplements before even seeking professional assistance for their children, there is no evidence that these dietary supplements are beneficial for ADHD. Indeed, one large study of omega-3 fish oils as a supplement for managing ADHD that was conducted in Sweden found that there was no benefit at all for children with ADHD, that is, the combined type. But the study did find that about 25% of children with the inattentive form of ADHD, sometimes called sluggish cognitive tempo, did show some modest improvement in their inattention symptoms from having taken the fish oil. But the degree of improvement was less than 1/3 that obtained by ADHD medications. So at this point, that study needs to be replicated, but nonetheless, even it found that for the routine type of ADHD known as the combined type, supplementing with fish oils or omega-3 fatty acids was not beneficial for ADHD. Now, a very popular intervention in the United States in particular for ADHD, especially within school systems, is sensory integration training provided by occupational therapists. Unfortunately, this training has been examined in scientific studies, and these studies find that it is of no benefit for children with ADHD, yet it continues to be provided as if it were. I discourage parents from availing themselves of this intervention either through the schools, through hospitals, or through private practitioners, given that the available evidence simply does not support its effectiveness for this disorder. It's been my experience that in many major metropolitan areas there are chiropractors who are willing to provide interventions for ADHD and LD children. Excuse me. These interventions go by various names, such as scalp manipulation or neurologic organization training, but essentially they involve massaging various points on the skull as well as at the roof of the mouth in order to readjust the neural networks in the brain that are believed to have been disrupted during development. And by readjusting these neural networks, it is believed that ADHD symptoms can be improved. There is absolutely no scientific basis for this theory, nor is there any science behind the claims of effectiveness for these interventions. Indeed, I am aware of absolutely no scientific studies on skull manipulation or skull massage as an intervention for ADHD. So I encourage parents to steer clear of chiropractic interventions for ADHD or LD. Some research has been done on the effectiveness of play therapy, psychotherapy, or other counseling approaches for dealing with ADHD children. these studies have not found that these interventions are useful for treating ADHD. Indeed, one very large randomized trial of play therapy conducted by John Weiss and colleagues at the University of California at Los Angeles involved both play therapy provided by master play therapist clinicians, done several times a week, compared to meeting with clinicians weekly for the same amount of time, but not engaging in play therapy. There were no differences between this attention placebo condition and the formal play therapy intervention. Now, as I mentioned on the previous slide, cognitive behavioral training has been studied for ADHD children, and generally the overall pattern of results is not promising. Therefore, we do not encourage families to use self-control interventions for working with their ADHD children. But as I did point out, it may be that cognitive behavioral training is a useful supplement for adults with ADHD. As I pointed out on the previous slide, several studies have found it to be effective and to improve ADHD symptoms beyond those improvements obtained by medication alone. But this is not the case for children, and therefore I list cognitive training of children as an ineffective or unproven intervention here. I also mentioned previously that social skills training, when done by clinicians in clinics, has not proven particularly beneficial for ADHD. This is especially so for the combined type of ADHD. But some studies have found that the inattentive type of ADHD, particularly that subset of children having sluggish cognitive tempo, may benefit from social skills training. Please take my course on diagnosis and subtyping of ADHD on this website for more information about this relatively unique subtype of ADHD. But suffice to say that garden variety ADHD, known as the combined type, does not appear to benefit much from social skills training when it is delivered by clinicians in clinics. Now, some research does show that if the training program is done in the school environment with the children that the child has to get along with at school, that it may provide some benefit for social relationships in that school setting. This does not, however, generalize to settings outside the school in my experience. Also, as I mentioned on the previous slide, training parents to be friendship coaches with their children might be a useful alternative to clinic-based social skills training. As I mentioned, this is an intervention where the parents are trained to be social skills trainers themselves, known as friendship coaches, and therefore parents can institute the interventions in the natural environment as normal opportunities for social relationships arise, in order to use these opportunities to train and reinforce their children in more appropriate social skills. Time will tell if friendship coaching is a useful treatment, but it may be a better alternative than clinic-based social skills training. These are just some of the references that support some of the claims made on this and previous slides. Before discussing some of the particular ingredients of counseling parents about their ADHD children, I'd like to review just a few key points on why why psychosocial training should be instituted with ADHD individuals. After all, why not simply write a prescription for an ADHD medication and be done with it? Medications are in fact the most effective intervention we have for ADHD in children and adults, often resulting in more than twice as many individuals responding to the intervention and nearly twice the degree of improvement from the intervention that is obtained by psychosocial interventions. But still, I argue that it is useful to combine a package of interventions involving both medication and psychosocial treatment, and this intervention is based upon the following conditions, or the following reasons, that is, for why a combined package is better than medication only. First of all, we know from medication studies that many individuals do not comply with the medication regimen, and that typically, after a few months or up to a year, up to half or more of the individuals are no longer taking their medication as prescribed or taking it at all, so that non-adherence to medication intervention is a problem. We also find that research studies show that combining psychosocial with medication treatments often results in greater effectiveness of the intervention than does providing either modality alone. For instance, this was the result of the large multimodal treatment study of ADHD conducted during the last decade by the National Institute of Mental Health. That study found that combined intervention was more effective for most individuals than was medication or psychosocial treatment provided alone. But that study also found that medication alone was superior to psychosocial treatment provided by itself. Oftentimes, combining psychosocial treatments with medication, I think, better prepares parents and teachers for managing the ADHD child during the times of the day when the child needs to be off their medication, particularly in the evening hours when the medication has been worn off and the child's problems still have to be contended with by the parents. Also, psychosocial interventions may be needed to address particular comorbid conditions that are associated with ADHD, that ADHD medications will not be beneficial for treating. For instance, ADHD medications are not useful for treating learning disabilities, which are often comorbid with ADHD, and tutoring and other psychosocial treatment programs may be needed to address those disorders. This is also the case with conduct disorder, major depressive disorder, and anxiety disorders, where we find little, if any, evidence that ADHD medications, particularly stimulants, are likely to be of any benefit for these comorbidities. So psychosocial treatment often has to be added to deal with the comorbid disorders that most ADHD children experience. Evidence also shows that when a combined program of psychosocial and medication treatment is used, one can often get away with lower doses of the medication and still achieve the same level of effectiveness as the higher doses of medication would have obtained. The combined program may also be able to address particular special populations of ADHD individuals where parent or child skill deficits exist due to low socioeconomic status or due to simply educational inopportunity to learn the skills. For instance, children coming out of disadvantaged neighborhoods or having been adopted out of institutions may well have social skills deficits as a consequence of this background. Providing social skills training may help to improve the social skills of these children, even if such social skills training does not address those social problems that are due specifically to the child's ADHD. The same can be said for parents who may come out of very impoverished backgrounds and who may have little opportunity to learn appropriate child behavior management methods. Here, these parents may benefit from training in child behavior management skills that can be used to improve their ability to deal with their children. And while these interventions may not necessarily address some of the problems that are due to the child's ADHD specifically, they can certainly improve the parent's ability to manage garden variety problems that any child may pose for this family. Finally, we know that combining psychosocial treatment with medication enhances the acceptability of the treatment package to both parents and teachers. Parents and teachers would rather see a child receiving something other than simply medication alone in order to intervene with a child's ADHD symptoms and related disorders. Therefore, a combined intervention may be more acceptable to the consumer than medication provided by itself. Now, when I am working with parents, or even with teachers, I like to review with them what I consider to be the 18 Touchstone ideas for ADHD management. Some of these were mentioned already in my course on ADHD and executive functioning. But let's go over them here because others were not mentioned in that course and need to be explained. First of all, I believe it's important to work on changing the parent's view of their child and of their child's behavioral difficulties. Many parents believe that ADHD or related symptoms of oppositional behavior can be automatically changed by simply learning better behavior management skills and applying them to the child. They do not realize that ADHD is a neurogenetic disorder, and that no psychosocial treatment program is going to be able to eliminate the disorder completely. Psychosocial treatment programs are designed to help parents and teachers cope better with the child's ADHD symptoms, help to reduce them even if they can't eliminate them, but especially help to promote greater effectiveness and success of the ADHD child in the home and school environment. But certainly one is not going to train out the ADHD by any psychosocial treatment program. So the attitude I like parents to adopt, I call parents are shepherds, not engineers. I like parents to adopt the idea that they are a shepherd to a disabled child. And like a shepherd, it is an important role for them to provide the most appropriate pastures in which to raise this child, pastures that are stimulating and that can help the child to be the most effective that they can be. But just as with a shepherd, you don't get to design the sheep. You don't get to change their personalities or their capacities or their abilities in any strikingly appreciable way. You are not an engineer. And so I would prefer that parents view their role as one of trying to help a disabled child cope with their disability, reduce the impact of the disability on impairments in various life activities and domains, and especially improve the child's school success. But we are not going to engineer the ADHD out of the child. Now, as you learned in my course on executive functioning, ADHD interferes with a child's ability to use their sense of time for time management. And therefore, it's important to make time more external by using clocks and counters and other timing devices during tasks to help the child see the passage of time and to be able to regulate their behavior to that passage of time. One can also deal with this timing disability by reducing delays between tasks and consequences, that is, between behavior and the reinforcement and other consequences being used to manage it. The closer the consequences are in time to the behavior, the more manageable the ADHD child's symptoms will be. Now, to deal with the working memory deficits I've talked about earlier, it's important to put key pieces of information outside the child in settings where the child needs help remembering what the rules are and what the most important pieces of information are that they should be following at that time. So I refer to this as externalizing working memory, and that is making important information physical, using sticky notes, charts, signs, cues, lists, and other means of recording information and putting it in the child's visual fields at key places of performance in the environment, so that the child can benefit from this external prompting and cueing of the rules and the consequences. Now, as you know from my course on executive functioning, ADHD interferes with the ability to self-motivate. And therefore, people with ADHD are more dependent on external sources of motivation than on internal sources of self-motivation. This means that we have to arrange for artificial consequences around the ADHD child if we expect that child to be able to sustain their work-related behavior over time. In other words, there must be something in it for the child if the child is going to be able to sustain their activity over time. Now, this can be things like privileges, points, tokens, money, snacks, treats, or other reinforcers that can be arranged to occur in the work environment for the child and provided sporadically or periodically throughout their child's performance of the task in order to motivate the child to sustain their action over time to complete the goal. And I refer to this as externalizing motivation. Now, in my course on executive functioning, I explained that individuals with ADHD, because of their working memory problems, are not able to mentally manipulate information that is needed in order to help solve problems, such as math problems, for instance, where the problem has to be set up in mind and the individual has to engage in mental management or manipulation of the problem in order to solve the math problem. One way around this, again, is to come back to this key word, externalize what you're doing. In this case, make problem-solving manual. Children, for instance, with ADHD could do their math work by having a stack of marbles or other things that they can count and sort and group, by having a number line, by having an abacus, or some other device that allows them to manually manipulate the key pieces of the problem in order to help solve it. External manual problem solving can therefore supplement mental manipulation and problem solving in helping the children to solve the problem and complete their assignments. For more information on manualizing problem solving, please take my course on executive functioning on this website. Now, as we've already said, feedback for children with ADHD needs to be provided more frequently and more immediately, and the consequences have to be more salient in order for the individual to benefit from the consequences. Indeed, the ideal period of time after a behavior has been performed for a consequence to occur is about 10 to 15 seconds or less. And so we need to arrange for children with ADHD to receive more immediate, that is, more quick feedback from others as to how they're doing if we expect them to sustain their appropriate behavior over time. This also means that we must increase the frequency of consequences, not just the timing of the consequences, in order to improve the child's motivational difficulties. One way to do this is to make the child more frequently accountable to others, such as parents and teachers, across the day, in order to hold them accountable for what they agreed to do, for what their assignments are, and for their appropriate prosocial behavior. So frequent meetings, extended across the school day or the day at home, can help benefit the ADHD child by having them meet with a parent or teacher, review what they had agreed to do, provide rewards and other consequences at that time for how they have done, and then set new goals for the next time period before the next accountability checkup is to occur. This is a lot like coaching for ADHD adults, where someone calls the adult daily, if not several times a day, in order to discuss with them what their goals were, how much progress they're making to attaining the goal, and provide them with further encouragement, support, acknowledgement, and recognition for attaining the goals that they have. Now, we also know that ADHD children are likely to get bored with these behavior management programs and consequences, and therefore one needs to use more powerful consequences that are more meaningful to the child, and sometimes more artificial consequences like tokens or privileges or star charts or other means of recording points and tokens in order to help the child realize that they are earning rewards toward a goal. And then they can cash in these tokens or other salient rewards for privileges that they would like to have. Now, because of this propensity for boredom, parents and teachers have to change the rewards they are using on their token system menus in order to keep the program interesting and rewarding. So, interviewing the child periodically about any new interests they have or new rewards they would like to see put on the program, and removing rewards that the child no longer seems to be interested in purchasing, can help keep the token system relatively dynamic and interesting for the ADHD child, and therefore motivating of good behavior. Now, we also know that ADHD is not the result of lack of information, and therefore we tell parents and teachers that they should not spend so much time talking to the ADHD child or lecturing them or engaging in moral essays or extended conversations about what the child should or should not be doing. Instead, I believe what we should be doing is what Ed Christofferson and colleagues have been encouraging individuals to do at Kansas City Children's Hospital for many years now, and that is to touch more and talk less. If you want to say something to an ADHD child, whether it's an instruction, whether it's praise, or a reprimand, go to the child, put your arm around them or touch them on their hand or arm, look them in the eye, and very simply state what it is you wish to say. Keep the conversation short, direct, and therefore you'll find that the ADHD child is likely to pay more attention to you because of the contact, the physical contact, and is also more likely to do what you say because you've kept the conversation: direct, short, sweet, and to the point. So, keep instructions and conversations down and use more physical contact with the child in order to get their attention. Related to this is a point that Sam Goldstein often makes in his lectures about managing ADHD, and that is to act and don't yak. Basically, this means to manage the consequences in the behavior management program and to provide more frequent and immediate consequences and more accountability to the child, as we've already mentioned, and stop spending so much time yelling, screaming, nattering, reminding, arguing, and so on with the child. It is the management of the consequences that will change behavior, not providing more information and hot air to the child through arguments, nattering, and nagging, and so forth. It also helps in raising any disabled youngster to maintain your sense of humor and to realize that the child is not engaging in these behaviors to intentionally get you angry or get you upset or ruin your day. Sometimes, in fact, some of the child's inappropriate behavior can be quite humorous, and it helps to laugh with the child around these occasional mistakes that all of us are likely to make, ADHD or no ADHD, in our lives. Now, I also encourage parents to adopt reward programs first when they're trying to change a behavior, rather than to adopt punishment programs first. This is because research shows that children with ADHD are being punished already significantly more often than our normal children, and therefore instituting punishment is not likely to result in any further improvement. Indeed, this is because research shows that what makes punishment effective, are two parameters. The first parameter is the amount of reinforcement that's available in that situation for the positive alternative behavior. If there's no reinforcement available or minimal rewards available, then the child is unlikely to adopt the prosocial behavior that you are trying to get them to use, and therefore no amount of punishment is likely to lead them to engage in that appropriate behavior. Second, we also know that it is not the duration of the punishment, its severity, or the extent of the hardship it is imposing on the child that makes it effective. This is counterintuitive, but it is actually the speed with which the punishment is instituted that is more important in determining its effectiveness than is the amount of hardship being imposed. Swift justice works, and therefore mild punishments can be quite effective if they're instituted quickly within 10 to 15 seconds of the initial onset of misbehavior, rather than having the parent remind and natter and argue and repeat their threats until finally, after 20 or 30 minutes, the parent is so fed up they eventually institute a consequence such as timeout or removal of a privilege, and then parents complain why this approach to punishment isn't working. It's the delay to the punishment that's the problem. So, we encourage parents to, first of all, increase the availability of rewards, approval, attention, respect, and other positive consequences for appropriate behavior in that situation. Do that for several weeks. And then you can institute mild punishment programs should some misbehavior be continuing in that situation. But even then, the punishment needs to be instituted quickly. And if it's done that way, then relatively mild forms of brief timeout, response cost, loss of privileges, or other consequences can be successful. Now, ADHD interferes with executive functioning, and it's the executive system that allows an individual to anticipate the future and prepare for it. This means that people with ADHD cannot anticipate the future as well as people who don't have the disorder, and therefore they're going to need assistance in doing so. Therefore, if a project is due, or if a long-range task is being engaged in with a child, like a science project, or a book report, or any other long-range assignment, parents need to anticipate that deadline, or teachers need to anticipate it, and then break the task down into small daily quotas. Make a plan. Do a piece of the plan a day. And when the deadline arrives, the child has accomplished the work and can meet the goal. But assigning long-range projects to people who cannot anticipate the future, like ADHD children, is a losing strategy. The individual will forget the deadline. They cannot deal with time itself. They cannot engage in appropriate time management, and therefore the project is not likely to be done. So we anticipate that parents and teachers anticipate problem situations and deal with them effectively by breaking them into small daily quotas, and that will help the child to anticipate and prepare for the arrival of the deadline and then be ready when it finally does arrive. We also encourage parents to identify what is a priority and what isn't, and to let some of the non-priority slide for a while they work on getting the child to adhere to the priority task at hand. For instance, it is not important that a child make their bed before going off to school. And so if parents are arguing over whether or not a child has made their bed or picked up their pajamas or put their dirty clothes away, and so on, before school, parents should stop imposing this particular demand on the child because it has no developmental significance. Instead, on school mornings, they need to focus on whether or not the child is up on time, dressed, well-fed, and prepared to leave school with the materials they need for school, and to do so with the knowledge that their parents are supporting them and believe in them. It is this approach to these goals that is more important and has developmental consequences, and not whether or not a child has engaged in some particular cleanup activity at home before going to school. So help parents to identify the most important priorities at the moment. Let the non-priority tasks slide for a while, and you will find that life at home will be much less conflicted, and that the child is more likely, I think, to succeed at the priorities. Now, Gordon Serfontaine is a clinician in Australia who once said that ADHD is a hidden disability, and I couldn't agree more with him. Unlike other disabled children, such as children with Down syndrome or cerebral palsy or other physical disabilities, ADHD has no physical sign that a disability is present, and therefore the child looks normal and may talk normal and even act normal briefly. And so it's hard for people to understand that this child actually has a neurogenetic disability that's as real and as brain-based as other disabilities might be, such as Down syndrome and cerebral palsy and autism. So I remind parents that almost every day they have to remind themselves to maintain a disability perspective, that is, to view their child as a disabled child who is in need of their assistance and compassion and support, and not be drawn into believing that there's nothing wrong with their child, and therefore believing that their child is acting disobediently, willfully. Nothing leads to parental vindictiveness than believing that your child is intentionally misbehaving in order to get you upset. Finally, I believe that one of the key ingredients to counseling parents is to have them practice forgiveness. And here I mean forgiveness as three things. First of all, learn to forgive your child for their mistakes. They're going to make plenty of them during the time that you have them at home. And so you had better get good at overlooking some mild mistakes and forgiving others. Second, you better become more competent at forgiving yourself for your own mistakes. Everybody makes mistakes in raising their children, even professionals. And so I encourage parents to adopt a different attitude. Yes, you want to strive to get it right, but if you make a mistake, you have a second chance to strive to get it right the next time. It is, after all, this attempt to get it right that is most important, not to be perfect. We know that coping models are better for people to learn than are perfect models. And so I encourage parents to be a coping model. Admit your own mistakes, admit them to your child, ask for forgiveness, and then go on and try to get it right the next time. Finally, parents need some help in learning to forgive other people about their ignorance about ADHD. For instance, the example I use is when a parent has a child in a grocery store and the child begins to misbehave. Parents are likely to find themselves being looked at by other individuals in the store, often with scorn. And so I encourage parents to develop a relatively thick skin toward other people's looking at them or even making comments to them, because these people don't know that the child has ADHD, or even if they do, may not understand ADHD the way the parent does. That is, that ADHD is a disability. And so parents need to get good at forgiving others their ignorance about the disorder. I actually spend time in my conference sessions with parents going over these 3 forms of forgiveness and encouraging them to adopt them. Now we come to some specific components of actually counseling the parents directly, besides those that I have already covered in the previous slides. When I meet with parents for an initial session after the feedback conference, I like to spend time with them discussing the nature of ADHD, its causes, its life course, and its potential risks for impairment. You can learn more about these various aspects of ADHD by taking my other courses on these topics on this website. I also spend time with them going over all of the treatments I've discussed with you in this course, those that are proven, those that may be experimental, and those that are unproven. Parents have limited resources in order to get treatment for their children, and we don't want them squandering these limited treatment resources on disproven or unproven interventions. So help guide the parents toward the most appropriate therapies for their children and how to combine them into a package like I discussed on the first slide in this course. I also encourage parents to read widely about ADHD and not just take it from me. So I certainly make them aware of books that I have on the subject of ADHD, as well as other books that are out there. They can go to the addwarehouse.com and see a number of books that have been written for parents explaining ADHD and its management. They can also go to my website and download a fact sheet on ADHD, or better yet, go to the chad.org website, which has fact sheets on ADHD as well, covering a variety of topics. But read widely. Truth is an assembled thing, and you don't get it from one expert. So I want parents to become more knowledgeable and more expert about the disorder, and I encourage them to find a variety of sources to do so. But by all means, do not tell the parents to simply Google the word ADHD, because they will find 4 to 5 million responses, and there's no way that a parent has time to sort through the diamond from the dung heap of the internet. So I encourage parents to check out about 10 websites. You can find these websites on my website, russellbarkley.org, where you can connect up to these other websites. Or you can download the readings list that I have provided on this website, and you'll find at the end of that readings list the websites that I recommend, such as chad.org, add.org, help number 4, ADHD.org, provided by the federal government, and other such useful, informative websites about ADHD. After discussing the nature of ADHD, I do emphasize that for most children, ADHD is likely to be a chronic handicapping condition. My own longitudinal studies show that more than 2/3 of ADHD will be ADHD in adulthood. About 15 to 30% may outgrow the disorder. The remainder appear to continue to have higher levels of symptoms than normal, but not necessarily enough to warrant being diagnosed with the condition. Nevertheless, the vast majority of ADHD children will be ADHD adults, and so I want these parents to adopt what I call the chronic handicapping view of ADHD, and I often refer to ADHD as being analogous to diabetes. Parents with diabetic children have to learn about diabetes and how to alter their family functioning, the child's diet and exercise and hygiene and other programs in order to cope with and lessen the secondary consequences of unmanaged diabetes. And it's very much the same approach with ADHD. Our goal is not to eliminate the ADHD. After all, we can't do that. But our goal is to help parents cope better with it, help the children to be more effective and successful, help to reduce the symptoms where possible, and especially help to prevent the secondary harms that can occur if the ADHD is not managed. For instance, such secondary harms might be having to be retained in grade, losing friends, failing at school, getting into car accidents as a teenager, not getting along with other children in the family, not getting along with other children in the community, being kicked out of clubs and sports and organizations because of misbehavior. Crime and drug abuse are known secondary consequences of unmanaged ADHD by adolescents. So, by explaining all of this to parents, you can show them exactly why ADHD needs to be managed on a day-to-day basis to prevent these secondary harms from occurring. Now, when one discusses any handicapping condition with a parent, you can expect a grief reaction. This may be subtle, and it may be that it's something that the parent experiences at home out of your view. But I formally mention this to every parent that I have counseled about ADHD, that they're likely to grieve the diagnosis, and that is normal. No parent likes to hear that their child has a handicapping condition that is likely to be chronic into adulthood. But the reason I do this is to have them come to terms with their child's disability. Because, after all, the end stage of a grief reaction is acceptance. And that is where we want this parent to be before we're going to be able to have them learn strategies and methods and adopt treatments that will be useful for managing the child's ADHD. If they don't accept the child's disability, they will fall prey to the many charlatans that are out in the community or on the internet who are willing to sell them any promise of a magic cure for ADHD. So to protect them from these charlatans, I like to have parents understand that a grief reaction is likely, but that the end stage of grieving is acceptance of the disabled child they have been given, rather than longing for a child that they did not receive. Now, following the grief reaction, I spend time with parents discussing what I call the 30% rule. This helps them to lower their expectations to a more appropriate level for a child who has a disability. Now, I came up with the 30% rule many years ago because the question arose in my mind as to just how delayed are ADHD children in the development of their executive abilities and self-regulation. And I went through various papers at the time, and I calculated how far behind the ADHD group was from the normal control group in these various studies. And it turned out that on average, it was about 30 to 35%. With a range of somewhere between 20 and 40%. And so, as a clinical rule of thumb, I came up with the 30% rule, and it works like this. If you want to know where your child is in their development of self-control, in their executive abilities, or what I call their executive age, take 30% off their chronological age. Now you know where they are, and now you know what they are capable of doing, and no more. And therefore, for you to demand or insist that your child behave in these areas as if they were normal is an impossible expectation. It can't be done. It can only result in arguments and conflict and disappointment and even a sense of vindictiveness. Instead, if you understand where your child is at in their development of self-regulation, then you understand that this is all you can expect from them, and that you will have to rearrange the environment and specific tasks and your rules and so forth in order to meet these expectations. For instance, a child with ADHD, a third grader for instance, who might be about 10 years of age, is not going to be capable of doing third grade length assignments, even if he is able to understand third grade level academic subjects. The ability to persist over time, to organize oneself relative to an assignment, to even have a good sense of time, and to problem solve and self-motivate during the task are all executive abilities, and this child is going to have an executive age of about a 7-year-old, and therefore they're not going to be capable of persisting at third grade length homework or schoolwork or even home responsibilities. Parents need to break the task down to that of someone who is 7, break it into smaller quotas, and rearrange the task as if the child were a 7-year-old, and then the child is likely to succeed. I have found that teaching parents the 30% rule results in significant improvements in family functioning, because the parents have now changed their attitude toward the child, have altered their expectations, and that alone results in reduced conflict with the child. It also makes the parent more willing to make accommodations for work and for other assignments that the child is given in order to help the child, because making these accommodations is simply a way of following the 30% rule and making the task fit the child's executive age instead of trying to torture the child to adopt an executive age that they are incapable of adopting, that of a normal child. So, I suggest that you do the same. Work with your families and counsel them on the 30% rule, and share it with teachers as well. Now, another thing I work with families on is how to modify the points of performance in the environment in order to deal with a problem with executive functioning. So let me explain. If you've taken my course on executive functioning, then you know what I mean here. But if you haven't taken it, give me a moment here to explain it. The point of performance is the place in the environment where you need to remember what you know in order to successfully perform that situation or task. Now, when an individual has an executive deficit, they are much less likely, because of their working memory and other problems, to be able to recall and implement information that they're holding in mind at the point of performance. And therefore, we need to change that place in their life to make it more likely that they can remember what they know and show what they know and be more effective. For instance, if a child forgets to take their book bag to school every morning, then the book bag should be packed the night before and placed at the front door, literally in the way of leaving the home, so that it's likely to be remembered. Parents can also post rules and cards and notes. Teachers can do the same on the child's desk in order to help the child to remember key pieces of information that are needed for that task at that place in time. In other words, at that point of performance. Having what you need at the point of performance and having it represented outside of you in your visual fields is a way of dealing with executive deficits, particularly those involving working memory. And so we like parents to understand this idea of the need to make changes in key places where tasks have to be done and rules have to be followed to help the child improve at the point of performance. Now, as I've already mentioned, when you discuss with a parent that their child has a disability, one of the things we are trying to do is to get them to accept the child as disabled and therefore to advocate for this disabled child. And so I formally discuss this with parents as two of the roles they're going to need to play as a parent raising a child with a disability. The first role is that of accepting the disabled child for who they are, and the second role is that of advocating for this child for services they may need outside the family environment, such as at school. As we've already mentioned, encouraging routine physical exercise is useful for coping with and reducing ADHD symptoms, and hopefully for also trying to address the risk ADHD children have for obesity. Now we come to a topic that is, of course, one that I have been involved in for many years of my career, and that is developing parent training programs for children with ADHD, and especially for oppositional defiant behavior. Now, there are many such parent training programs on the market, and I encourage you to explore the one that is most suitable to your clinical practice. But all of them are quite effective at helping parents of ADHD children to reduce the conflict they have with their children, to improve their child's oppositional behavior, and to some extent to improve the child's ADHD symptoms. Now let me give you a list here of the various programs that are in the marketplace today. Certainly there is my program, Defiant Children, which you can explore at my publisher's website, Guilford.com. This is a training manual for how to conduct each session of training with a parent, including handouts, the various problems you're likely to encounter, and how to solve those problems with parents. Another program is the age-old program that goes back to the late 1960s and early 1970s, which is Wesley Becker's book, Parents Are Teachers, available, I believe, still through Research Press. A very good introductory course to child behavior management methods. There is also Jerry Patterson's program on managing child behavior problems that you can get through Castalia Publishing on the internet. Sheila Iberg has developed parent-child interaction therapy, somewhat similar to my own program for defiant children, though it also emphasizes some exercises that are believed to be helpful in improving parent-child bonding and relationships. The Triple P program for positive parenting, developed by Matthew Sanders and dads out of Australia, is a widely available program throughout the U.S. Charles Cunningham, a good friend of mine at McMaster University, has developed the COPE program, which is a program for teaching parents how to manage misbehavior in children. Cunningham's program is very similar to my Defiant Children's program. Part of the reason for that is, of course, is that Dr. Cunningham and I trained together at the University of Oregon Medical School, now the Oregon Health Sciences University in Portland, where both of us learned the basic components of this program from the late Connie Hampf. There is also the Incredible Years program developed by Carolyn Webster Stratton. Its components are similar to my program and to the Cunningham program, again in part because Webster Stratton also trained at the same medical center and also learned many of the same treatment programs that we learned from Connie Hampf. There is also the program developed by Richfield called Parent Coaching Cards. You can simply Google this on the internet and find out how to purchase these coaching cards, which are simply large cardstock cards that have on them various reminders of behavior management methods. Parents are encouraged to place these cards around the home where particular problems are likely to occur with their child, and to consult these cards before deciding how to deal with particular child behavior problems in that room and situation. Indeed, you can combine the Richfield program with my own program in order to boost its effectiveness. Tom Phelan has had a program on the market, along with videos, known as 123 Magic, which follows many of the same behavior management recommendations that you're likely to find in these other management programs. And then there is the more recent program developed by Green and Ablom, known as the Explosive Child Program, or sometimes called Collaborative Problem Solving. This approach is often useful for dealing with children with bipolar disorder, severe mood disorder, or other disorders that predispose them to very impulsive, explosive, destructive, and aggressive behavior. This is a non-confrontational program that does not teach parents limit setting, which is often part of the programs listed above, and instead encourages them to use a collaborative problem-solving approach with their emotional child in order to get their child to behave more appropriately. So I encourage, pardon the interruption there, so I encourage clinicians to adopt any of these parent training programs and to explore them at their leisure and find one that suits their particular approach to clinical management. As I've said, you can certainly take a look at my own program, Defiant Children, at my publisher's website, guilford.com. Now, let me review my program with you so that you can see some of the components of a typical parent training program. As I've already said, in my program, the first session is spent reviewing with parents the nature of ADHD, its causes, course, and management approaches. Then I also explain to parents oppositional behavior, and that is because parent training really is designed to address more defiance and oppositional behavior and misbehavior more generally than it is designed to reduce ADHD symptoms specifically. After all, ADHD is a neurogenetic disorder, and we don't expect to be able to eliminate it simply by teaching parents to manage contingencies of reinforcement in the home environment. On the other hand, oppositional defiant disorder is likely to arise in part as a consequence of disrupted or inappropriate parenting. Indeed, if you'll take my course on comorbidity, or my course on the importance of emotion in ADHD, you will see this four-factor model of oppositional disorder explained in detail. Suffice to say here that oppositional behavior arises out of four factors, one of which is the child's ADHD and problems developing executive functioning and self-regulation. But another is parenting itself and disrupted parenting, inconsistent, indiscriminate use of consequences, high rates of expressed emotion such as yelling and screaming, and vacillating between the use of lax and harsh punishment in dealing with children are all factors that make up disrupted parenting and have been shown to contribute to the evolution of oppositional defiant disorder in children. The third factor is the parent's own personality, and especially the parent's psychopathology. Many parents have adult ADHD, depression, drug abuse problems, or other disorders that interfere with their ability to appropriately parent young children, particularly children with ADHD. So, again, all the more reason to screen parents for their own disorders and to intervene with those parent disorders in order to improve the likelihood that they will benefit from training in child behavior management methods. Finally, the fourth factor has to do with family stress events within the family situation. We know that stress upon parents can, even temporarily, disrupt their ability to manage their children on a consistent basis, and that alone can lead to an increase in oppositional defiant behavior. So we like to identify these four factors in order to set the stage for the parents to begin to think about them and begin to identify specifically what four factors may be involved in their own family and with their own child, and then to take steps to begin to address each of the four factors in the model. Of course, this training program itself is designed to address one of those factors, and that is disrupted parenting, because parents are going to be trained in very specific behavior management methods designed to improve their parenting and hopefully, therefore, improve their child's behavior. Now, after going over the four-factor model, we then engage in training of the parents in very specific management techniques. We begin by helping parents increase the amount of attention, positive reinforcement, approval, respect, dignity, praise that they provide to their child throughout the typical day. We will help them with various exercises at home in order to encourage them to adopt this more positive relationship with their child. Notice that we do not start out working directly on problems. We do not teach punishment right out of the gate. Instead, we focus, as I said, on improving the available reinforcement for prosocial behavior, and that is what helps to improve the likelihood that punishment may work when it is finally adopted. We then work with parents specifically on attending to their child when their child complies with directives and requests. And we also train parents on various ways of improving how they deliver such commands to children in order to improve the effectiveness of the command being obeyed. Then we focus on how to get children to leave you alone and quit disrupting you when you are busy doing other tasks. In other words, how to encourage children to play independently of you. In this session, we train parents in a shaping technique in which they use frequent reinforcement to reward their children for leaving them alone and to continue to increase the period of time the children are able to play independently while the parent has to be busy. You can read more about these methods in my book, Defiant Children. Next, we help parents set up a home token system for their child. Essentially, we do this with children who are at least 5 years of age and older. Below 5 years of age, we do not believe that children have the cognitive development to fully understand the nature of a token reward as a secondary reward, and therefore, for children who are below 5 years of age, we have parents work directly on providing treats or privileges or praise and attention to their children, and simply skip the intermediate use of tokens to mediate the connection between behavior and those consequences. Nevertheless, we will help parents set up their lists of chores that they want the child to do, rules they want the child to follow, and then a second list of privileges that the child can purchase with the tokens that they're going to earn in the program. Then we help them to determine the price for each of the privileges the child is going to earn, and then the cost, or excuse me, the amount that the child is going to be able to earn by the various chores and rules that the child can follow at home. So you've got two lists. One is a list of chores and rules. The other is a list of privileges, and you need to establish what price you're going to pay the child for following those rules and doing those commands, and then establish a price that the child has to pay to get access to those privileges. Then we have the parent use the token system for 1 to 2 weeks. At that point, we are likely to work with parents on improving their use of punishment tactics. And here we teach them 3 different levels of punishment. The first is response cost, and that is removing privileges or tokens contingent on misbehavior. The second is using timeout, where the child has to sit either in a timeout chair or on the first step of a stairway leading up to a second floor of a home as the timeout location. And this is instituted for only 1 or 2 misbehaviors for that week. And then thirdly, we teach parents that if the child attempts to escape the timeout location, that the child will then be placed in their room and the door will be closed and locked if necessary in order to impose the timeout in the child's bedroom. So those are the 3 levels of timeout, of discipline that we teach in the program. Finding or response cost, instituting timeout within 10 seconds of a misbehavior, and if the child will not stay in timeout, then isolating the child to their bedroom. We will now spend 2 weeks going over these punishment tactics with parents, having them select 1 or 2 misbehaviors to apply the punishment to, and targeting only those 1 or 2 misbehaviors. Parents are not permitted to use timeout, especially ubiquitously, for any problem they wish. They must choose a problem, target it with timeout, use the timeout for that repeatedly over the next week, and then once that behavior improves, they can expand their use of timeout to other misbehaviors. One of the techniques that we teach next in this program is called transition planning. It's mainly taught to help parents deal with misbehavior when they're away from home, such as on shopping trips or in church or when visiting other people. But it can also be used between any major transition of activities that takes place even within the home environment. Let's consider a situation in which a parent is about to take a child on a shopping trip and they're about to enter a shopping mall or a specific store. Transition planning would involve the following. First, stop before you enter this situation, this building. Next, go over with your child 2 or 3 rules you expect them to obey. Keep the rules brief. Now have the child repeat these 2 or 3 rules back to you before you enter the store. The rules in the store, for instance, might be: stay next to me, do as I say, don't ask for anything. The child must repeat these rules. Then the parent explains to the child what they can earn in the store by obeying these rules and generally behaving well. What's the reward or incentive? These can be tokens or points that are part of the home token system if one has already been set up. Or the parents can simply promise to buy the child something at the end of the trip, such as a snack or a small toy if they wish. There's absolutely nothing wrong with making this offer. This is not a bribe. A bribe is where you offer something to somebody to do something illegal or immoral. This is an employment contract where you are specifying that in exchange for the child's work, in this case obeying the rules, the child will be able to earn something. But explain the incentive. The next step is to explain what the punishment will be if a rule is broken. Generally, we tell parents that they can fine their child by taking away some points or a reward, or they can remove whatever they promised to buy the child at the end of the trip, or they can institute timeout either in the store, in a convenient, quiet, out-of-the-way location, such as the women's bathroom, or they can time the child out outside the store, facing a wall away from the store, or in the back seat of the car if necessary. But they need to have a punishment in mind and explain the punishment to the child. So now you see that we've gone over the rules, explained the incentive, and explained the punishment. Now we want to make sure that before you enter the store, the child has something to do with their hands, because ADHD children like to touch things. They're very busy and manipulative. And so we encourage parents to bring a toy like a Game Boy or a Nintendo DS or a Rubik's Cube or something that the child can hold and play with while in the store. So this is the time to bring out this device and give it to them as you enter the store. Now, enter the new situation and prepare to follow your plan. In fact, the plan is more important than what you are shopping to purchase. So we ask parents to keep this in mind. Indeed, as part of the exercise in this step, we often have parents go out on pseudo-shopping trips. That is, shopping trips where the only reason they're going out is to train. They have nothing to buy. They're not looking for anything. There's no priority. They're simply taking the child out in order to engage in training, so that when they really do have to go shopping for something important, the child has already had some training occur. Next, we encourage parents to reward throughout the trip. Don't wait until the shopping trip is over, but give the child tokens every few minutes during the store for following the rules and obeying the parents' commands. Finally, at the end of the shopping trip, evaluate how well the child has succeeded. At this point, you can either purchase something for the child, or you can give them additional tokens besides those you've already dispensed during the shopping trip itself. But have the child also evaluate their own success. How do they think they did, not just how the parent thinks they did. Now, another technique that we use during this behavioral parent training program is we teach parents how to monitor their child's behavior away from home, specifically at school, and we use a daily school behavior report card to do so. So we have these cards made up in our clinic. You can make them up very easily using the table function in your word processing program, but create a daily school report card. Now, in this report card, along the left-hand side, as you see here, is where you want to place the rules that the child is to obey in that situation. Here I've chosen some of the more common rules that ADHD children have trouble with at school. Across the top of the card, you want to have enough columns so that each teacher can evaluate that child during the time that they have them during that day. For instance, this might be a column for each subject, such as reading and math, and one for gym, and one for the child's history and language classes, and so forth. Along the bottom, make sure that there is a row so that the teacher can initial their rating to ensure that the card has not been forged. Now look at the top of the card and you'll see the instructions we like to give to the teachers, which is to ask the teacher to rate this child's behavior in their class that day using a numbering system from 1, which is excellent, to 5, which is terrible. So teachers are to put in the numbers 1 to 5 in the column under their particular subject, so that the child is to be rated on 1 to 5 on class participation, on performing classwork, on how they followed rules, and so forth. At the end of the day, the entire card will be filled, and the child is to take it home. The parents, when the child gets home, ask for the card and review the numbers on the card, looking for, first of all, the best ratings, and talking about the good situations that happen, and then selecting the poor ratings, such as ratings of 4 or 5 on the card, and discussing what went wrong and what the child can do well tomorrow to succeed in that situation. Then the parents are to convert the ratings on the card that you see here to points, and the points are specified in parentheses. So for ratings of 1, 2, or 3, the child has a chance to earn points. That's why you see the plus there. For ratings of 4 or 5, these are not good ratings, and the child is going to lose points or be fined for every 4 and 5 that occurs on the card. So now add up the positive points, subtract out the penalties. The remainder is the balance the child has to spend to earn their privileges at home. Obviously, this card needs to be connected to a home point system, where the child has a list of privileges that they would like to earn at home, such as time on video games, or time using a cell phone, or time spent outside playing, or visiting a friend, or having a sleepover, or going to a movie, and the usual privileges that children like to earn on a daily and weekly basis in their families. Each of these should have points listed next to them for the price that the child has to pay in order to earn those privileges. And the points to purchase the privileges are being earned off the daily report card. Now, this report card can be used for a variety of purposes. First of all, it's being used to inform the parent as to how well the child has done in school that day. Second, it can be used to determine when the child's medication might be wearing off prematurely during the school day. So if this is a child taking medication, and we routinely find that the last 2 class periods of the day are troublesome for the child, it might indicate that the child's medication is wearing off too quickly, and therefore a discussion with the child's physician about altering the time course of the medication, such as through dosing or switching to a longer-lasting delivery system, might be beneficial. But finally, and most importantly, this card is being used to connect the child's school behavior to consequences at home, especially important consequences that are meaningful to this child. It is this connection of school behavior to home consequences that is very important, because it is here that we will find the motivating aspects of the card that encourage the child to behave well at school so that they can earn the privileges they want to have after school that day. Now, I don't like using this report card for children who are in first grade or younger, but I have found it to be successful for children in second and third grade all the way through high school. One simply has to adjust the privileges that the child wishes to earn to the appropriate age of that child. Now, parents can also use a report card like this for monitoring their child anywhere that that child is away from home and under the supervision of another adult. So they could adapt the card, for instance, for the Cub Scout meetings, or for when the child goes to their particular after-school sports, or if the child is in a Sunday school program, or any other place that the child might be supervised by another adult. Simply create a card that has the rules you want the child to obey on it, and have the other adult fill out the card using the ratings that you see here. And then when the child comes home, the ratings are converted to points, as I've already discussed. You can also use this report card for when a child stays with a babysitter and the parents are going out for the evening. The babysitter can evaluate the child's behavior every 15 or every 30 minutes that the parent is away, and give the child their grades, their scores, for how well they've behaved during the previous 15 to 30 minute interval. Now, in this case, one would simply put rules on the card that are appropriate for the child's home behavior. The point here is that a card like this can be monitored or used to monitor a child's behavior anywhere that another adult is in charge of supervising this child. And then parents can provide consequences when they meet up with the child again for how well the child has behaved away from home or with this other adult. So, we've now covered 2 additional sessions in my program: transition planning for dealing with children in public places, and setting up a daily school behavior report card, or just a monitoring card for when children are away from you. The last 2 sessions of my parent training program are simply a review of all of the prior skills that have been taught to parents, and getting parents to think about future problems they might have with the child and how they could use the methods they've learned in the course to deal more effectively with that child's behavior. We then schedule a 1-month booster session to see how the family is doing. Or, if necessary, we will now shift into another form of treatment that may be needed to deal with one of the other comorbid conditions that the child has. Research shows that parent training programs like this one enhance routine clinical care of ADHD children and help to boost the effects of medication. They also boost a parent's sense of competence in dealing with their child and their child's ADHD. Also, research routinely shows that parent training programs like this one reduce oppositional defiant behavior and parent-child conflict, and may even reduce to some extent internalizing symptoms like anxiety and depression that the child may experience. But don't expect the programs like this to reduce or eliminate ADHD symptoms completely, though oftentimes research shows that programs do have a positive effect on ADHD symptoms. Now, it might be useful to quickly review some of the predictors of positive responding to such parent training programs. In other words, are there things that might predict which families do better in these programs and which are not likely to do well in them? And the answer seems to be yes, and here you see a variety of predictors that have been identified. Obviously, parents from very low-income families or who have a very low educational level may not benefit as much from these programs, or, in my experience, they benefit, but they need to go through the program one-on-one with a clinician, and they're going to take more time from the clinician in order to be able to understand and adopt these management methods. So I think that family income and parent educational level are simply an indicator of when parents should not be trained in a group with other parents, but are going to need one-on-one individual parent training, and probably more hand-holding and explanation during each of the sessions. Another predictor is the severity of the child's behavior problems. That's not to say that more severe cases do less well, although they might. But it is to say that, once again, these are cases in which individual parent training rather than group parent training may be best. I've also found, however, that where the child's disruptive behavior is so severe, explosive, and destructive that perhaps the child has childhood bipolar disorder or a severe mood disorder, that it may be best to manage those disorders first and reduce the severity of the problems before entering into a child behavior management program. Now, research also recently has shown that children who have psychopathic traits, known as the callous unemotional traits of lack of conscience, lack of empathy, lack of guilt and remorse for their misbehavior, and predatory aggression, that these children should not be put into behavioral parent training programs right away. Instead, these children need to be treated with ADHD medications first, and then, once the child's medication has been titrated to an appropriate therapeutic level, take the parent through the parent training program, because research shows that such psychopathic children do not benefit from these parent training programs unless they're on ADHD medications. Obviously, the parent's own ADHD has been mentioned earlier as a predictor of failure in these programs. Screening parents for their ADHD, getting them appropriately diagnosed and treated for it, should be done first before then engaging in behavioral parent training with them about managing their children. Obviously, parental psychopathology, particularly maternal depression, has been shown to interfere with a parent's ability to successfully go through this parent training program. I've already mentioned parental educational level as not so much a predictor of failure, but as predicting which parents need more one-on-one attention from the therapist and should not be dealt with in parent training groups. The degree of prediction of all of these, however, is quite weak, especially for all but family income level, and parental ADHD and child psychopathic traits, known as callous unemotional traits. Those three are the best predictors. The others are relatively mild or minor predictors of success. Nevertheless, as a clinician, you might want to screen parents and families for all of these predictors to determine whether or not this family should receive parent training. If they do, should it be done in a group, or if not, should it be done individually? Finally, let me talk briefly about an intervention for ADHD teenagers or teenagers with oppositional defiant behavior. As I said earlier, parent training programs like the one I've just discussed lose their effectiveness with age, and after 11 to 12 years of age should not be the sole or primary intervention, because only about 25 to 30% of families are likely to respond to them. It is at this age where I believe we have to start working directly with the teenager themselves, as well as with their parents, on what we call problem solving and communication skills, or, if you will, the art of negotiating conflicts. Now, Jerry Patterson years ago developed just such a program called Parents and Adolescents Living Together. And also, more than 15 years ago, Arthur Robin and I, along with Gwyneth Edwards, created a very similar program to the Patterson program. All of these programs break the training program into three component pieces, and here they are. The first of these is to spend at least 6 to 8 weeks working twice a week with the family on problem solving. Problem solving involves 6 explicit steps to resolving a specific conflict or dispute. These are the routine problem solving steps that you learned in any introductory psychology class. For instance, they would encourage the parents and the teenager to first of all define the specific problem. Is it curfew? Is it staying out later this Friday night? Is it playing music too loudly? Is it the friends the teenager has? Is it chores the teenager has to do? Define the specific problem. Step 2. List all of the possible solutions you can think of without criticism. So this is the problem solving, this is the creative aspect to the therapy hour. So have the family list as many possible ideas as they can think of, and there is no criticism allowed. Next, in this set of 6 steps of problem solving, we want the family to go through each explicit step, that is, each explicit solution they have come up with, and now is their chance to evaluate it, to give an opinion about it. What do they think? Do they like it or not? Could it be workable? And go through each step. Now, after they've done that, they will find one that they're most likely to all 3 agree on. They are to circle that step, that solution to the problem, and then they are to turn this into a behavior contract with the teenager. In other words, all parties agree to follow this solution to the problem for the next week. Then the parents are to specify a consequence for the teenager if the teenager fails to comply with the contract. That is, what is the teenager going to lose? And also, what is the incentive? What will the teenager earn if they follow the contract appropriately? Finally, at step 6, I also like to specify a consequence for the parents, because sometimes parents will engage in this approach to problem solving in the clinic, but not follow through on it when they get home. And so the parents may have to provide something to the teenager if the parents break the contract. So, for the next 6 to 8 weeks, parents and teens pick one problem at a time and go through problem solving and setting up these contracts with each other. Now, after about 6 to 8 weeks, it becomes rather apparent that the real problem the family is having is in their communication skills. A lot of times we find that the parents raise their voice or swear or issue ultimatums or scream or yell or use obscenities or other forms of negative communication styles that can terminate problem solving with someone. Similarly, teenagers are likely to be engaging in very similar kinds of tactics with their parents. So we now spend 6 to 8 weeks training parents and teens in positive communication to use while they continue their focus on problem solving, such as having the teenagers sit up straight, look at their parents, having the parents speak calmly with no obscenities or ultimatums, and having the parents listen to the teen before saying what they wish to say, and vice versa, all forms of positive communication. Finally, for some families, we have found that after about 12 to 16 weeks of therapy, we find that there are present certain irrational or unreasonable beliefs, and we try to identify them for the family or have them identify them. For instance, a particularly irrational belief might be blind obedience. This is a belief held by parents, where parents expect their teenager to do everything they say, no matter what, and with no discussion. This is an irrational belief to have about a teenager. And so one way of dealing with this is to first of all explicitly identify it as irrational. Have parents think about other families they know that have teenagers and whether they believe that that teenager also is likely to do everything their parents tell them to do without question. If necessary, you can assign what we call data gathering or experimentation. Have these parents call a number of other parents and ask them whether their teen does everything that they're asked to do without question. Of course, they're going to find that the teenager doesn't. And then, of course, using some humor is also a good way of getting parents and teens to cognitively reframe these unreasonable beliefs into more reasonable beliefs. The teen may also have an unreasonable belief, for instance, what we call ruination, and that is if I don't get my way, such as if I don't get the family car to use this weekend, I will be a social pariah in high school on Monday. This, of course, is a gross distortion of reality and needs to be identified as such. There are many such unreasonable beliefs that you can find in our treatment manual. Our treatment manual is called Defiant Teens. And it's the equivalent manual of Defiant Children for this particular approach to family therapy. You'll find in here a number of parent handouts and strategies for working with families of oppositional teenagers. In conclusion, I hope I've shown you that counseling of parents about the nature of ADHD and approaches to its management is an essential step in the diagnosis and treatment of children and teens with ADHD. I hope I've also shown you that training parents explicitly in behavior management skills is an empirically proven, science-tested form of intervention that can result in significant improvements in family functioning and relationships, in child oppositional behavior, and to some extent in a reduction in the child's ADHD symptoms. Finally, I hope that you've learned that parents may come into treatment with their own disorders, and these disorders can interfere with the parent's ability to acquire the treatment program that's to be used for their children. And therefore, disorders like parental ADHD, depression, substance use programs, and so on, substance use disorders, and so on, need to be identified and screened in parents whenever parents bring a child in for an evaluation. And those parental disorders will need to be addressed first or coincidentally with providing the counseling and behavioral parent training programs to the parents. Thank you for taking this internet course on parent counseling and behavior management at home. I invite you to take more of my courses on ADHD on this website at your convenience. I also invite you to visit my publisher's website, Guilford.com, for my latest products in the ADHD marketplace, such as my 3 new rating scales for assessing adults with ADHD, published in the spring of this year, along with my other books on ADHD in this marketplace. Thank you again for taking this course. I hope you have found it informative.